Please join me in welcoming our panelists. Thank you for being here. Now, simply by way of context and backdrop, the frame for our conversation, you all understand what Medicare is. Many people talk about Medicare. For one thing, people often confuse Medicare with Medicaid, one of the many mistakes people make. Let me give you the basics. Medicare is a government-administered program that guarantees access to health insurance to Americans aged 65 and older, as well as younger people with disabilities. It was created by Congress and signed into law in 1965 by President Johnson, one of the many reasons that it is fitting for us to be in a building bearing his name today. Before Medicare was in existence, half of older adults did not have health insurance. Half before Medicare did not have health insurance. On the day that Medicare was signed into law, President Johnson said, "The need for this action is plain, and it is so clear indeed that we marvel not simply at the passage of this bill. What we marvel at is that it took so many years to pass it." 2010 statistics, 48 million enrollees in Medicare, 40 million of whom are older Americans. They expect that 78 million people will be enrolled in Medicare by 2030. The number of workers per Medicare beneficiary is falling. It was 4.6 when the bill was signed into law in 1965. It was 3.3 last year. It's expected to be 2.3 in 2030. So by 2030, from the time the bill was signed into law, the number of Medicare number of workers per Medicare beneficiary will have fallen by 50%. Disproportionately, Medicare enrollees are white, female, and poor. 16% of Medicare enrollees were living in poverty in 2008. 3/4 are part of a single-payer health care plan. The rest are in a network plan. On average, Medicare covers roughly half of health care costs. The rest are paid by the enrollees themselves. In 2010, the cost of the federal government of administering the Medicare program was $523 billion. By 2020, just around the corner, it'll be $932 billion. Medicare trustees said last year that the Medicare Trust Fund will be insolvent by 2024. Medicare spending per American household was $129 in 1970, almost $8,000 by 2021. And then one last statistic, Medicare spending as a percentage of the whole economy, 3.6% in 2010, 5.6% by 2035, and 6.2% by 2080. Medicare is growing faster than the rest of the federal budget. Representative Coleman, is it as dire as all that? Do you believe what these statistics are telling us, that this program is just hurtling off the cliff?
No. And the reason is that government has priorities, and we made a promise to the people of the United States of America, and particularly the people that you said are on Medicare.
Yeah.
It's a divorced woman who was waiting to get to that 65 years old so they could actually have health coverage. It's people who are widowers and widows, and it's something that says something about our country, that we actually believe that people with disabilities and people over 65 are valuable people to our society, and that costs money. Other people believe that the military is value, and that costs money too. So the thing is, what are the priorities of the country, and what choices are made in terms of the budget in Washington, or, by the way, budget in Austin? Most people don't know that $300 million was cut out of what's called the Part B in Medicare. That's the part that pays for someone who's over 65 that's in Medicaid and pays the physician. That was done away with in the last session of the legislature for individuals.
And that tells you about the priorities, at least, of our budget writers.
That's correct.
Right. Dr. Goodman, Representative Coleman has argued passionately on behalf of the obligation, but didn't address the question of whether the economics are ultimately a problem that's going to turn us upside down.
Sure. Here's what was missing from your summary.
Yeah.
Basically, the Affordable Care Act, what some people call Obamacare, has solved this problem on paper. And basically what the law requires is, going forward, Medicare will really grow no faster than the economy as a whole. And if it grows no faster than the economy as a whole, then almost by definition, it's affordable. The problem is, these first two charts in this handout I gave you come right from the trustees' report. I've never seen them in a newspaper. I've never seen them in anything produced by ARP, but you can go to the latest trustees' report, and there they are. And what the actuaries are telling us is that the way in which the Affordable Care Act solves the problem of Medicare is it just gives less to doctors and hospitals.
Right.
And so going on forever, the hospital payments fall further and further behind what all the private payers are paying. For doctors, in another year and a half, it gets below Medicaid.
Right.
What the chief actuary says is 1 out of 7 hospitals will go out of business, will go out of the system before the decade is out. Seniors will have more difficult time seeing doctors than Medicaid patients do today.
So the cuts to providers,
Yeah.
that's how the Affordable Care Act, as you describe it, gets us to a place where we
Right,
can
now,
afford the program.
Right. If you listen to the president, vice president, they say we found $716 billion of savings. In fact, they haven't found any savings. There are some demonstration projects and pilot programs trying to find savings.
Right.
But the CBO, Congressional Budget Office, has looked at these on 3 separate occasions and said, no, they're not finding any savings. It's not going to work. And so the fallback is what the chief actuary said. He didn't even take any of that seriously. He's just saying, we're going to cut providers, and it's going to be serious, and seniors are going to be hurt.
Right. And so the future of Medicare, as we say, basis for this conversation, is bleak if that is the route there.
Well, the problem is that no one in Washington thinks it's going to happen. They think that when you all can't find a doctor, that you're going to be on the telephone to your congressman and your senator and say, why can't doctors see us? You're not paying them enough.
Right.
And then Congress will go back and undo all of this, and if it undoes it all, then we're back to the problem you
Back to the
described.
original problem.
Yes, right.
Ms. Dunkelberg, Dr. Goodman makes it sound like the Affordable Care Act is ultimately the Unaffordable Care Act. We can't afford to have this kind of a cut.
Well, I actually wasn't prepared to answer that particular question,
Okay.
but I guess what I'm hearing is, I think actually even progressive experts on Medicare
Yeah.
agree with Dr. Goodman that, and with the actuary, that healthcare spending, the percentage of GDP that it takes up and the rate of its growth do have to be addressed. Right. But it's
An area of agreement probably.
that's an
across the
area of
family.
agreement. I think that what should not get lost in the details is that there are a lot of different ways to approach balancing the books and getting the cost under control, and it is possible to do that in a way that keeps healthcare providers and society at risk for keeping that cost down, rather than shifting it randomly to individual seniors, which is what we're concerned about with some of the proposals that are on the table today. And I think, the vision for social insurance and a social safety net for seniors in healthcare that we're looking for trying to retain in Medicare, even in a vision where a lot of changes need to happen in our healthcare system, is one where it's not enough for it to be solvent. It needs to be solvent, yes, but that's not enough. It needs to both be solvent and be adequate to meet the needs of potentially our highest cost healthcare population, and one which, as you've noted in your introduction, is predominantly low income people on fixed incomes. Right. And a population that it has, with all due respect to all of us who are aging, which is better than the alternative, one that has a declining capacity for doing sophisticated consumer research on thousands of different clinical options that they may have in front of them. So we need for it to be fairly simple for consumers. We can't rely on extensive research by every senior consumer to keep down the cost of Medicare. We've got to have systems that drive that.
But you're not taking issue, Ms. Dunkelberg, with the basic economics at work here. You agree that the
saying
growth
that-
of healthcare costs is a problem that has
Yes,
to be done.
although it should be reminded, I think everybody probably knows this, but that if you look at the cost per sector, that Medicaid's costs have grown slowest per person in Medicaid, then Medicare, and then private insurance and private healthcare spending in general are growing at like
Not
2
right.
percentage points
Not right. No,
higher than.
No, not right. Not right.
Well,
Not right.
I would cite some sources that would
I've
make
seen the
that
chart,
case.
but the chart is wrong. The Congressional Budget Office looked at this, and there's no evidence that Medicare per capita spending per patient is growing any faster or slower than the private sector.
Well, I'd be interested to see the workout of those numbers. I'm certainly seeing those numbers coming from a lot of reliable sources.
Well, as we say in grade school, we can all
And
show our work maybe, actually, and that way we can see.
If you look at the CBO table, there's a beautiful CBO parfait chart that shows all of healthcare spending in the entire U.S. economy, and the private segment of it is much larger than the public segments, and it's growing at a faster rate. So my only point is we have to get healthcare spending trends under control across the entire healthcare economy, not just in Medicare, not just in Medicaid.
Mr. Linbeck, what we're hearing break out a little bit here is an argument about what the priorities of our country should be versus the reality of the economics of this. I don't think anybody would dispute what Representative Coleman is saying, that we want to help people who need help, but obviously the cost to the federal government is increasing at a rate that's not sustainable, whatever the solution is. Where do you come down on this?
Well, I mean, this system right now is taking on all the hallmarks of a centrally planned system, right? We've got 311 million people in the country, and we're trying to come up with one solution that fixes that for everyone, and that's just a flawed governance structure, right? And what's most important, before you get to policy, you have to talk about governance and who should decide.
Right.
Like, I do not argue that the government should not be involved in healthcare. The question is, which level of government? Right? Is it going to be closer to the people, or is it going to be at a remote group that's making these decisions for everyone?
Right.
And frankly, when you get it and you elevate it to that federal level, we get exactly this kind of debate, right? And everything becomes polarized because it's winner take all for everyone. And in fact, what we need is a lot of diverse solutions. Texas is different than Vermont. And frankly, a single payer system may work really well in Vermont. It's 750,000 people, right? So, why not let them try that? They want to. They've passed a resolution to do that. Texas may or may not want to do that, Utah, et cetera. And there should be a lot of diversity in terms of the different solutions and a sort of a regulatory competition to see who can do it best.
And so in your mind, power should be returned to, I'm guessing, the states?
Well, yeah, I mean, the states, it's not like the states are bastions of virtue, right? I mean, so... I mean, look, it's still, like, it varies by state, though, right? I mean, Vermont's 750,000 people. And look, I know single payer works at the scale of 7, right? I got 5 kids. In my household, there's exactly 1 payer for health care, right? So I know that works. As you scale that up, it will probably break because it becomes this big centrally planned gargantuan deal. Is 750 too big? Well, I don't know. Let them try. But Texas is big, and we ought to move it down further. And that's a lot of what's going on with the Medicaid waiver, I think, right? I mean, we're essentially talking about taking the dollars and pushing them down to local communities and saying, look, why don't you figure this out? You're there. You know your populations. Let's do it. And I thought it was tremendous that the Obama administration gave that waiver.
Yeah.
And now the question is, what do you do with it, right? I mean, that's...
Well, as you say, not all states are bastions of virtue. They may do good or they may do ill, right? Let me ask the Vice Chairman of the Select Committee on Federal Legislation whether he thinks that the federal government perhaps wants to step to the side and give the states the power to litigate these questions themselves.
Well, states do have the power to litigate at least the Medicaid portion. And Medicare has been unique in that it is a single payer system. Everything else is a partnership between state and local government, and payments go to private providers. So, those are payments that go out in our system and employ people. I think the hospitals would argue with you that if some of this goes away, they're not going to survive anyway. And they believe that reducing the cost of health care is extremely important to all of our future. I was lucky to do something at Harvard. It's called Understanding the New World of Healthcare, but it's mostly physicians, and they were cardiac specialists. And their primary caseload were Medicare. We took them through an exercise about what the reimbursement rate was versus how we pay for government, and had them do an exercise on doing the federal budget. And in fact, you can't have everything now. I mean, so the reality of this is there's a blend of things that can be done, but as long as people are fighting like we're fighting, there will never be a blend of policy that actually gets us to a place that is sustainable, because we're in these win-lose situations instead of win-wins.
Would you trust, as I appreciate Mr. Linbeck's candor about the states, would you trust the state of Texas to play a larger role in administering these health care rather than the federal
No,
government?
not this leadership.
Was that enough
but,
of a softball question, Representative?
but no, I would not, because I mean, I've been, since 2003, I've watched using the excuse of no money when we had money,
Right.
to cut back on services to people in Texas that have a need, disabled, elderly, children. So no, I don't have a lot of trust that this group is interested in that. But I trust Leo Linbeck, because we were in 4th through 8th grade together at St. Anne's grade school.
We both had a lot more hair, Garnet,
you
at
know,
the time. So.
But the reality is, when you have a group of people who's responsible for health care for people who are needy or have no way of getting it other than an emergency room, that doesn't think government has a role, then that's not the person you want designing the future of that program. Now, if we came together with people who believe the government has a role and people who don't believe the government has a role, but the objective is to make sure that people aren't, literally dying in the streets, and I say that because of where we're going, I think we can get something done. But it's, I don't think that Texas, if you go back under states' rights, that Texas was particularly generous, except for our county indigent system.
Ms. Dunkelberg, to Mr. Linbeck's point, what works in Vermont doesn't necessarily work in Texas, right, is his argument. We have a particular kind of population in this state. We are rapidly growing. We added 5 million people to the state population rolls in the first decade of the century. I believe 85% non-Anglo, 69% Hispanic. We're moving quite quickly toward a Hispanic majority state. Are there things about the unique nature or the particular nature of Texas that tell you we would be better off controlling how we allocate health care and health insurance to people?
As opposed to?
Well, as opposed to a one-size, what I think Mr. Linbeck is describing, kind of a one-size-fits-all model that exists across the states.
As you know, I'm more of a Medicaid expert than a Medicare expert,
Yeah.
so I'm especially focused on the 15% of Medicare beneficiaries who are the poorest and
Yeah.
who are eligible for both programs. And, despite the fact that states complain about having to comply with minimum standards in Medicaid, there is phenomenal variation among the states in Medicaid programs.
Right.
And so I think that both, and I'm not saying there's no room for improvement by any means, but I think there is an enormous ability to adapt solutions to different states under existing law. And like I say, I'm not suggesting that there's nothing that needs to be improved about the ACA, Lord knows, or existing Medicaid or Medicare statutes.
Right.
But I think there's an enormous amount of flexibility there and all sorts of opportunities. You can have different kinds of health plans. You can create basic health programs. So there are a lot of options right there for states to do things differently, and I imagine Texas will do a lot of things differently.
Dr. Goodman, you wanted to get in on
Well,
that.
I think we're focusing too much on the form and not the substance.
Okay, let's talk about the
And
substance.
in fact, it really doesn't make any difference whether it's single payer or multi-payer or public or private. All of these insurance schemes are working the same way. Most people don't realize it, but who really runs Medicare is Blue Cross and other private insurers. And they function pretty much the same for Medicare as they do when they're private insurance. And the problem with all these systems is that they are terribly wasteful in the way they buy health care. There's an article in the New York Times this morning that explained that there is no drug approved by the FDA that Medicare won't pay for. Doesn't matter how expensive it is, doesn't matter whether it is no better for your health than a really inexpensive drug, Medicare still pays for it. There's probably not a hospital in Austin that Medicare isn't paying in its network. There's probably not a single doctor in Austin that Medicare in principle won't make payments
And your
to.
view of what ought to be the case as opposed to that is what?
Well, look what Walmart's doing. Walmart announced the other day that they've picked out the 7 best hospitals in the whole country. These are low-cost, high-value, high-quality hospitals. Scott and White in Fort Worth is one of them. And if the employee will go to those hospitals for the knee replacement, the heart surgery, and so forth, Walmart will pick up the whole tab and pay the travel costs. The employee can go someplace else, but then the employee is going to have to pay the extra cost, $5,000 or more out of his own pocket.
Representative Coleman, you don't like that very much.
Well, the thing that people complain about is a single operating system like a clinic. Scott & White's not insurance. It is you buy into their plan, you see their doctors, they're all one thing. And if you're out of town, there is no Scott & White. It is an efficient system because the middleman has been taken out, and that's the insurance company, because they don't need one. Because you have to live in proximate to that hospital for it to work. That is a system where it's smart and it's good, but it's also, if somebody calls something socialist, that is exactly what that is, in the fact that you go to this set of clinics, this hospital, and use these doctors.
Isn't that the absence of choice, Dr. Goodman?
But for Walmart, remember, Scott & White is competing against every other hospital in the country, and Walmart picked out 7 that they said are the low cost, high quality, and we're going to send our employees there. So they are, in fact, competing. It is a free market, and Walmart's one of the very first employers in the country that said, okay, we're going to start being a smart buyer of health care.
Ms. Dunkelberg?
Again, I would say substance is in the eye of the beholder, perhaps, but to me, the issue is not whether Medicare can and should be experimenting with aggressive ways to see if you can get the best care at a low price. And there's been lots of research lately by folks we think highly of that suggests that some of the best quality care is also some of the least expensive. The question, really the fundamental question is there going to be a true social insurance protection for seniors so that they know they are protected from more than some narrow range of out-of-pocket costs in getting all the care? So going after all of these changes is great as long as I'm not doing it by shifting all of the liability to the senior rather than having the system and the providers in the system share the risk, the system in society, share that risk.
Mr. Linbeck.
Yeah, so there are a couple of issues around that. First of all, the current structure of the system is kind of crazy, right? Because just at a real practical level, I've got guys working for me on a construction site I'm paying $15 an hour to, right? Unskilled labor. I'm taking tax money from them, sending it to Washington, D.C. to pay for my dad's health care. Right? I mean, that's just nuts.
Who's a millionaire, by the way?
well, my dad is. Anyway. So, so if you look at that from a social safety net standpoint, we are covering all of these people who don't need it, right? But the politics of that on a winner-take-all at the federal level is such that there's no way you're going to break that, right? And if you change the structure of the decision-making, which, by the way, is already local, if you take the Medicare, what comes out of CMS for Medicare by provider location and by resident location, so who's getting the service, who's delivering the service, and you overlay those, there's like a 2% difference, right? So almost all healthcare is being delivered in the state to a resident of that state. And we federalize this, we turn it into a winner-take-all, it becomes extremely partisan and just huge interest show up, right? The big pharma guys, they love doing this in Washington. The big insurance companies love doing this in Washington. They've just got one regulator to co-opt, right? That's a whole lot easier than co-opting 50. So as a result, the whole thing gets dysfunctional, largely because we didn't get the governance question answered correct. Who should decide? Who should decide? And until we fix that, this thing will continue to morph into a bigger and bigger centrally planned system that at this scale has never succeeded anywhere.
Ms. Dunkelberg, you talked about in reference to what Dr. Goodman said on the cuts to providers in the Affordable Care Act, that there are lots of different ways to look at this. The alternative to the Affordable Care Act, at least from a political poll standpoint right now, is some version of the Ryan/Romney-Ryan/Ryan-Wyden plan, which is largely housed in, well, it's some version of that, wherever we happen to be in the particular point in the conversation. But it all adds up to essentially, we're going to give people a voucher. We're going to give them some version of a voucher that will allow them greater choice to go off and make a decision, and if there's a cost over and above that, they'll have to bear that themselves. Do you not see the value of giving people more choice by way of turning back money over to them and letting them pick their doctor or pick their provider? Philosophically, is that a problem for you?
Oh, not the choice part. Yeah. Again, I think that we get lost in the details of that delivery system. there are some fairly conservative economists like Gail Walensky and Antos, is that his name? Anyway, who have said, we support this model, but only if there are protections that make it completely ironclad that no plan can cherry pick, and thereby sending the traditional Medicare model that they're proposing to leave in place into an adverse selection spiral, et cetera. And so that's not a trivial detail, because what it goes back to is the principle that I opened my remarks with. Are you going to give seniors a guarantee and protection, or are you going to shift the risk onto them because you can't figure out and don't have the political will to truly get healthcare spending
And so
under control?
a voucher program or something that employs vouchers as a way to create choice, you think shifts too much risk onto seniors?
The scenario, the scorings of both the older, more severe version and the latest version of the Ryan plan suggest that seniors would end up picking up 2/3 of their health care costs.
Dr. Goodman,
ultimately.
you're shaking your head about that. You don't agree?
And if that were not true, I'd be delighted.
Okay.
But I think the point is,
Yeah.
if the folks proposing it were stand up and say, we guarantee
Right.
that this is not going to increase your out-of-pocket share, then I think that would change attitudes. But that guarantee is absent, and it was noted by Antos and Walensky that those promises were also
Dr.
absent.
Goodman, before you jump in, let me just say that before we came over here today, the Kaiser Foundation released a study on these so-called premium support plans, in which they said that the majority of Medicare beneficiaries would be expected to pay higher premiums under a premium support plan than they do under the current program. About half, 53%, in the traditional program would be expected to pay higher premiums for coverage. Among beneficiaries enrolled in private plans, 88% would pay higher premiums. They're basically making the point that Ms. Dunkelberg
Well,
is
you
making.
know, that all depends on exactly how you design it. But the reality is we already have a voucher program in Medicare. It's called Medicare Part C. These are the Medicare Advantage programs.
Right.
And 1 out of every 4 seniors is in these
Right,
programs.
about a quarter in those
private health
they're getting
insurance.
paid more.
And they like it. And they get a risk-adjusted payment to the plan. The senior may not even know this is happening, but Medicare has about 70 different things it knows about you, 70 different variables that go into the premium that it pays to Humana, for example, if you join a Humana plan. It's working very well, and in fact, it's working better than anybody realizes, because what does the Obama administration say that it wants to do to make healthcare efficient? They say they want coordinated care, integrated care, electronic medical records, medical homes, all this stuff. Well, where do you find this going on right now? In the private Medicare Advantage programs. They are pushing the envelope down in Houston, in Dallas, all over the country. This is where you find, these are the successful demonstration
So
projects.
you dispute the study that says that the costs are higher?
You can
I'm
design
going to
it.
take
You
as a
can
yes,
design
you
the
dispute it.
program any way you want. Yeah. We have it today. It works. Seniors can go back and forth to traditional Medicare, their private plan. We probably are overpaying these plans right now.
That's
Definitely.
what I was about to say.
Like-
It's subsidized. I do well too.
Dr. Goodman buried the lead, as we say in journalism, actually.
Well, if that's important to you, we just pay them less.
$1,100 per person.
That's a detail, though.
Yeah,
point,
but
Is that a detail, Representative?
that's an important detail.
well, the only reason we're overpaying them is because you got members of Congress like Bill Grassley who say, my God, we got to have them in rural Iowa,
let me
and so we're overpaying.
Let me just say this, when, talk about a subsidy. The subsidy that is actually the profit that the insurance company makes. They can't lose. So
and I'm not for that.
I understand, but that was put in by the previous administration. Matter of fact, it started a long time ago.
Congress.
They didn't call it. They didn't call it advantage plans. They called them something. It was Secure Horizons. You remember all that? That's when it first started. Matter of fact, they had Tom DeLay up there giving a deal in Fort Bend County with Secure Horizons Insurance Company. I'm saying all this to say...
Do you want to take that away from the folks?
No, I'm saying to you that the reality of it is that if the discussion we're having about the voucher is that it does the same thing that everybody has said they wanted to do in every program that we have. Medicaid, they want to cap the payment. They want budget certainty cap payment. And so the person who's supposed to pick that up is the person that's in that program. It's the same thing that businesses are doing when they say, okay, we're going to give you $5,000 worth of health coverage, And if that's it, and if you have a thing that's going on, you have to pay the other $2,000. The $5,000 stays constant. Healthcare costs go up, so your $2,000 becomes $3,000, $4,000, $5,000. And that's the problem here, because people with less incomes, and particularly people with fixed incomes, cannot afford the increase in the cost that's shifted to them that continues to go up. This isn't.
Well, Dr. But let me ask about what just Representative Coleman said specifically, because you said at the very end there, well, but if we're overpaying, we should just cut the payment back. Won't you be in a situation where if you cut the payment back, that you're either going to stick the additional cost with the enrollees, or you're going to cut the profit to the providers? You'll have the same problem you described with the Affordable Care Act, where the providers are going to say we're not being paid enough, we're going to opt out of the system.
Okay, a couple of points. First place, the people in the Medicare Advantage programs tend to be the very people Garnet was talking about. They're below average income. They're disproportionately minority. Many of them, most of them, could not afford Medigap insurance, which the other seniors have. So what these plans are doing is they're combining three things: traditional Medicare, Medigap, plus the drug coverage. When I say we're overpaying them, it's not that the companies walk away all that profitable. They give back benefits to the senior, up to $1,000 per senior per year, that they would have otherwise had to pay for. Now, if you take Medicare Advantage away from these folks, then they've got to go buy the Medigap plan at $1,000 or more per year. So I'm not terribly bothered that we're overpaying them, because it's satisfying a social need. And I know if you take Medicare Advantage away, there will be these folks over here will say, oh, we've got to help these people out. They can't afford their Medigap plan. So it's just one way of solving that problem. But what Ryan wants to do and what Romney wants to do is build on the Medicare Advantage plan. It's popular, seniors like it, it's working. And not only that, it's the place where you find all the stuff that Barack Obama really says he wants to happen in health care.
Mr. Linbeck, you don't like either the Affordable Care Act or the Ryan-Romney plan.
Well, what's wrong with you?
No, I mean,
Why not?
My progressive friends are going to rue the day they transferred all of this power up into the federal government, because someday Republicans are going to win control, and they're going to turn all of that power around and just jam it right back down their throat. This is the point. There isn't a solution at that scale. There isn't. These fights will go on for 100 years. Well, not that long, because apparently, according to the actuary, it'll be broke in 2024. Right, but up until that point, we'll have a great time, right? So, look, we're clearly heading towards a point where the thing's going to be insolvent. I mean, that's very clear. The actuary says that the Obama administration, through the ACA, cut that unfunded deficit from 80 trillion to 36 trillion, according to the. Okay, so that's great. That's progress. Now we're only down to $100,000 a person. Okay. Here's the problem. The edge of the cliff is way past the point of no return. Right? So if we're going to do something, we have to do something soon, because we're speeding towards that cliff. We're making promises to people we will not be able to deliver on, even if we give it a high priority. It's growing and growing and growing. And we need to focus our energy on the people who truly need the support, for whom it is really a matter of life and death. That is not most people in the system. But you will never get that to work out at the federal level. And yeah, states are not great. I absolutely admit that. But every problem we see in Texas is an order of magnitude bigger at the federal level. And it's winner take all. And that creates this polarization and this constant fighting. And it's never resolved.
Okay, so in the absence, Mr. Linbeck, of the world in which the power at the federal government is reduced and is transferred back to the 50 states, you say we've got to stop providing benefits to people who don't need them, who don't necessarily, we have to focus our efforts on the people who need them most. Why are we not talking about means testing for Medicare, if that's the case? I happen to know your dad. He's a great man. He also has a few bucks. He probably doesn't need Medicare, right?
I think that's fair.
Right?
Yeah. No,
Aren't there a lot of people around the state who have a few bucks and probably don't need Medicare as much as some of the people, like the 16% we described, who are living in poverty, or the people whose average household income, I think, is $22,000 a year, which is the profile of the typical Medicare. I mean, aren't there people who we should be means testing, right?
Yeah, now that I've thrown my dad under the bus, let me continue to
It's okay.
to
No one will see this video. It's fine. So it's okay.
Yeah, this is all off the record, right?
Right, of course.
So, look, Here's the problem. The structure of the Medicare program has been sold for years that you pay in and then you get yours out, right? As a practical matter, that's not what it's been. It's been a pay-as-you-go system.
Yeah.
So what's going to have to happen is that the people who've been paying into the system are not going to get the benefits out that they expected. Ideally, that ought to be the people who can already cover those expenses elsewhere,
Themselves,
like
right.
my dad, okay? But here's the thing. The American people have been very generous in terms of the way that they, I mean, look at what we do as a nation, right? And we can all argue that they ought to be more generous and that we ought to do more, but we do a lot, okay? When I've talked to seniors about this issue, they understand something has to happen. What they're not prepared to be is a sucker, right? So if you're gonna cut me, you better cut a bunch of stuff. Military, you better cut the growth of government in other areas. If there's an opportunity to do that, I think people would accept that. Problem is, it will never happen at the federal level. It won't. The politics are lousy. And the one thing you can be assured of is if the politics are bad, the politicians are not going to do it.
Yeah.
And so our only shot at this is to move the money, move the decision-making power back closer to the people, and let a whole bunch of different solutions emerge.
Well, Representative, again, with no disrespect to what Mr. Linbeck wants, let me come back to this question of means testing, which is in the absence of his solution, should we be means testing for Medicare and, by the way, for all the federal entitlement programs of this sort?
I think that let's allow people to opt out if they want to do that. They just don't get the money that they put in back to them.
You want them to self-means test?
Yes, self-means
Sort of
test.
like self-deportation we've heard about during this campaign? But do you think people will actually self-means test?
But no, I'm not being facetious. I'm trying to say that individuals are sicker today, and it doesn't matter what your income is. We live longer and it costs more, and that's what's driving some of the cost. And birth rates are up. And so when you look at that, but look at somebody like me, I have 3 chronic conditions. The reason it's important that I have a job in state government is because I'm gonna get health care with my retirement. My sister doesn't have any health insurance. Most people who wait to get to the point where they can have it don't have it. And that's the part that we miss.
Yeah.
And that in the person's need, if half the people in the United States in 10 years are gonna have diabetes, that means half the people that go into Medicare are gonna have diabetes if they live that long. So I'm saying that means testing doesn't do illness testing, and it doesn't say what the cost of those things are for those seniors who are there. It doesn't matter the wealth. They won't be able to afford it anyway unless we lower the cost.
But yet, Ms. Dunkelberg, to Mr. Lin, I'm sorry to pick on Mr. Linbeck's dad, but the example of Mr. Linbeck's dad is instructive because there are probably a whole lot of people who would not be in the system, and therefore some of the cost that's associated with the program would be diminished if those people either self-deported or were deported from the program.
Well,
Is that a question?
Yes.
This
We'll
is
let Garnet answer.
well, no, the deal is that again, it was a promise made, and unless people come together to continue that promise in a different way, and everybody agree that we're just going to have to make the hard choice, that's the way has to get done. But I think most people are afraid, just like the Ryan voucher plan, which I have in my pocket, that the savings is going to be on people who can't afford it, and that's what they're concerned.
But wouldn't I mean, we got Ms.
Should
Dunkelberg.
there
and then-
be, so we're back
But
to the question.
wouldn't the savings be on the people who could afford it if we said we're going to means test?
I think means testing is kind of like the questions of increasing taxes on households that earn more than $250,000 a year. It's probably something that we need to do, but it can become something of a red herring or a smokescreen because everybody knows that's not the only thing we need to do.
Yeah.
And frankly, the problems with solvency of Social Security and Medicare are things that can be solved by arithmetic. And the distraction is the real debate is just over whether or not you believe in social insurance or not.
So you think it's more of a philosophical question than a level up? What is the role of government, leaving aside some of the particulars?
Should we have
Right.
a meaningful social safety net for our seniors or not?
Or not,
And
regardless
make a
of their
commitment
income.
to it. Regardless of their income, and I don't, like I said, I'm not saying that that there's no room for means
Right.
testing. There are three ways to balance the books: more revenue, constraining healthcare spending growth, and beneficiaries picking up more of the cost. And what I'm saying is we should be looking at all three of those, not just one.
Dr. Goodman.
Okay, we already are means testing Medicare. If you're paying Part B premiums, I'm sure some in this room know, you make more income, you're getting socked with a higher premium, right? And we're also means testing Social Security on the benefit formula. The higher your income, the lower your rate of return to Social Security. I don't mind doing more means testing. I don't mind raising the age of eligibility. What I don't like about all this is that when we're talking about stuff like that, we're not talking about changing anyone's incentives. If you don't change incentives, you don't change behavior. If you don't change behavior, then you haven't solved any of our health care.
The cost piece of it is not.
Cost,
yeah.
quality, and access don't change. So if you look at the 10 ideas for short-run change that I gave you in the handout, they're all about taking advantage of competition, choice, market forces. They're all about changing the incentives for seniors and for doctors, and therefore behavior changes.
You and Representative Coleman and Dr. Goodman both brought up the question of raising the eligibility age. Let me ask, that's sort of the other thing that you hear often. You know, I believe the life expectancy has gone up dramatically. I know it's gone up dramatically since the time that Medicare was first signed into law. Governor Romney is actually on the record during this campaign as advocating for a change in the age of eligibility from 65 to 67. I think Vice President Biden was asked about a change in the eligibility age at the debate on whatever it was Thursday night of last week, didn't really answer the question.
Well, I'll tell you one big problem with all that.
What's the problem with it?
If you take seniors, people who are 65,
Yeah.
and ask what's their life expectancy, the top half of the income distribution lives 4 more years than the bottom half of the.
Exactly.
And
It's
over
not disconnected from class
and
or socioeconomic.
absolutely not. And over time, the gains in life expectancy have been primarily among above average income folks. And furthermore, it's almost a continuous increase. In other words, the higher your income, the longer your life expectancy. So yes, you can raise the eligibility age, but you're making lower income people bear more of the burden.
Mr. Linbeck, what about that?
Yeah, well, I mean, again, it's a classic situation where you try to engineer all of this stuff at the center, and it's unsolvable. It's just unsolvable, and it's the height of arrogance to think that we can come up with some kind of system that will sort of work for everyone at the center level, run by a group in Washington, D.C. It's just nuts.
Yeah. So you don't think the question of the eligibility age going up is
I think
legitimate?
every state could approach that differently. Every locality could approach that differently,
Right.
and it will vary. And there are clearly is an important role for government to play in this. One example that I'm fond of is catastrophic insurance, right? Clearly, catastrophic insurance, in order to get funded, needs to be funded through a tax. You can't opt out of that. Yeah. But if you focused on that and had government's role focused on that, the tax would be modest, and then the rest of the healthcare system could become much more efficient. Now, that's just one idea. The point is, there are dozens of great ideas.
Yeah.
Right now, to get them implemented, you have to go to Washington and convince 435 people in the House and 100 in the Senate, and that's just like a fool's errand for the most part.
Let me let Representative Coleman and Ms. Dunkelberg say a word about the eligibility age, then we're going to open it up for questions from the audience.
Well, you know, some people live a shorter period of time than other people, and it is particular to communities and income. And my concern is that somebody who really needs the health insurance is waiting longer to get it and is bearing a cost they can't afford.
Right.
And what I'm saying about that is because Leo mentioned the catastrophic, it's because they have cancer and no insurance. They have whatever else it might be and no insurance. So we're bearing the burden of that anyway. So by raising the age, that means those folks have nothing.
Of course, 65 to 67 is just 2 years. I mean, what Governor Romney is proposing.
Well, I mean,
it
I don't
seem like it's that long.
It's not that long unless you're sick.
Right, but you can,
You know, I
but
mean,
you
no,
can-
Evan,
yes,
unless you're sick, it's
Representative,
not.
You could just as easily get sick at 63.
Yeah, but if you go and do the actuarial tables, look at what age people get sick, and look at what they need in that period of time. And that's the thing. If it's illness related, or of course that costs more money, right?
Right.
But I thought we did the insurance to make sure that people who got sick could get health care.
Yeah.
I thought that was the purpose. And so if that's the purpose, then we are leaving people with nothing in up to 67. I call it, I used to say people waiting to get to Medicare between age, especially women, between age 55 and age 65. A lot of those women have no insurance. I mean, absolutely nothing.
Right.
Because and that's the big number. That's the big number.
Is right
and you
there.
brought it up.
Ms. Dunkelberg.
I think, Governor Romney is presenting that proposal in the context of also repealing the ACA.
Right.
If the ACA stays on track, and if the ACA were then amended to extend to age 67, currently it cuts off at 65, then there would be an alternative for the folks
Yes.
who are ill. And they
Right.
can't be turned down because of their illness or charged anymore because of their illness. Although they can be charged 3 times as much for their age, which I'm not looking forward to, but that's actually a fraction of the age difference we're seeing in Texas today. What I'm really concerned about, with inadequacies of the current Medicare proposal is the fact that it's only recently added a drug benefit, and that donut hole will not be going away if the ACA is repealed. It doesn't cover long-term care, it doesn't cover eyeglasses, it doesn't cover hearing aids, which are all the things I assume I'm going to most
At
need
that
as,
age, yeah,
the low-income senior that I will be on fixed income. So I think there's a lot, Medicare needs a lot of work, but going from 65 to 67 is not my primary concern.
Okay,
That's
final
what I'm
word, and then
making
we're going to
before.
open it up.
I
Yes,
want
sir.
you to look at this chart that shows the reduction in Medicare spending by age. And you'll see that for a 65-year-old, what the Affordable Care Act does is over the rest of his life, because of the Affordable Care Act, Medicare will spend $35,000 less on him. You could get the equivalent savings by raising the eligibility age by 3 years, going from 65 to 68. Now, for the 55-year-old, he's going to lose $60,000. That's the equivalent of a 5-year increase in the retirement age. And for the 45-year-old losing more than $100,000, that's like a 9-year increase in the retirement age. There are different ways of taking benefits away from people, but the bottom line is at the end of the day, the senior gets less, no matter what you do.
Well,
and none of this solves any real problem in the sense of changing anybody's behavior or anybody's incentives.
There's some premises you gave earlier that I don't accept either. But
Okay,
I
well,
just
go ahead.
didn't want to
Well,
jump in.
I can't let that hang there. Go ahead.
it's just-
Challenge this premise, and then we'll go.
Well, I mean, it's the idea that in this case, where you particularly said to Ann that her facts weren't right, but the piece is that as you raise those ages, that you assume that doctors get paid less, and then you assume that the savings is coming only from that. And I'd like to talk about that later, because I think that's a very important piece, because there are ways to deal with Medicare that we don't do now. So, for example, if it's fee-for-service, this is where the advantage plans come in. If it's fee-for-service and somebody can go to any specialist that they want to, up to a 7th opinion about their glaucoma, we shouldn't be doing that. So the reality is Medicare should work more like the system that basically we're all probably in. Primary care physician sends you to your specialist if you have a need. And yes, you can get a second opinion. This system now, people, they don't like the way that doctor is. They could go to whoever they want to.
Right.
Forever.